Hi, this is Long. Welcome to our video series on search patterns for the most common studies in radiology. Please note that this is an introduction to study interpretation. An enormous amount of detail is omitted for brevity. Continue dedicated reading, seeing as many cases as possible, and keep getting feedback from subspecialists during the course of your training. So today we're going to talk about a basic approach to ultrasound in pediatric patients for pyloric stenosis. Ultrasound is the imaging modality of choice, and it's essential to have a sense of not just the diagnostic criteria, but also how to troubleshoot some issues that may arise as you're actually doing the exam. So the basic overall structure of what we're going to do is you want to understand, what is the level of clinical suspicion, what are the patient demographics, any sort of, risk factors. And then you also want to get a sense, if there's any prior imaging. And then I think it's also useful to have an idea as to whether the vomiting is bilious or non-bilious. Bilious vomiting is generally, it's going to be consider like a more distal obstruction, so that whereas non-bilious is what you typically expect for pyloric stenosis. That can give you a sense as to your level of suspicion, and getting a sense as to whether the story fits for actual real suspicion for pyloric stenosis. As with all ultrasound studies, if you need to scan real time, that's something you want to do, and then once you are in the room and once you are obtaining diagnostic images, we'll evaluate the pylorus and then go through the various diagnostic criteria for pyloric stenosis, and then if there's any potential alternative explanations, we'll take a look at those as if they're incidentally imaged in the adjacent anatomy. Okay, so let's get started. So here we have a typical ultrasound for pyloric stenosis. Let's just go through quickly and kind of give you a sense of what these images will look like. So if you are, let's talk a little bit about how you get started on this. So once you understand the patient, and then you're scanning real time, it's very useful to start with the patient in like a right lateral decubus or right side down position. You can start with the patient with a probe on the epigastrium and move along the costal margin. And of course, this is much better to learn bedside with someone really kind of guiding you and has to do this. And you can use the liver as a window. As you can see on a lot of these images, the liver is actually, between the area of interest and the kind of pyloric portion of the stomach. This is true even on the static images here that we'll ultimately take a look at. And then you're going to want to have point the probe towards the right upper quadrant. You may kind of look near the gallbladder, which is going to be close. And that, and if you do see the gallbladder, you're going to, again, look like a little medial or inferior, and then that's generally the area you're going to find the pylorus. If there's like the patient's crying or there's too much bowel gas, you can kind of feed for a little bit, see if that helps, but don't feed, a large quantity, as that can kind of alter the anatomy so that the pylorus moves into a posterior or more inferior position. That can make it a little bit more difficult to see. So if there's like, significant gastric distension. Okay, so on these images, once you have good diagnostic images of the pylorus, you can take a couple statics, and you want to measure a single wall thickness as well as the length of pylorus. Wall thickness is kind of the preferred or like more accurate kind of criteria. If the single wall thickness is more than 3 millimeters, that's going to be something that you want to kind of be more suspicious. Like 2 millimeters is going to be considered normal. Generally 3 millimeters is equivocal. And then if you're clearly at the 4 millimeter mark, measuring that single wall thickness, that's going to be abnormal. And you want to be careful here, in particular, say like this exam, we have a good image where you're really kind of measuring the more hypoechoic area and not including this mucosa. So you want to be sure to do that. And you are doing just the single wall, not the double wall. You want to also take a look, and you again, this is where it's important to have a sense of that clinical picture, is that if you are seeing mucosal thickening, that could give you a little suspicion for formula allergy or some sort of gastritis picture, which could better fit or alternatively fit the clinical picture. So we're going to take a look at single wall thickness, which we're measuring, and then the channel length, where you can see if it's abnormal, especially about 15 millimeters. So as we look, and that's going to be if we get like a good image of the pylorus on a static. Here we go. We've got even a better one here with various measurements again. So this is going to be kind of below, close to the 2 millimeter mark. And then this is below 15 here, so that looks pretty good. And then, we got multiples. And then as we go through, and those are just the static images, you can note that where the stomach goes here. We do have some cines here, and this is something you want to be looking at real time. But this is something that we recapitulate on these images, is that if there is a concern for pyloric stenosis, you want to see, are you actually able to visualize stomach contents passing through the pylorus? So I think on some of these later images, we have a better view. So we see here, stomach contents making their way through. And if you, let's see if any of these later ones are kind of do better. Let's see. Yeah, I think our best set of images is right in the middle, where you can see that there's a little bit of gastric contents passing through. And with a lot of ultrasound examinations, this is often best seen at the bedside. But if you see more than minimal gastric contents passing through, that's pretty reassuring. That's very reassuring that you're not dealing with pyloric stenosis. If the findings are equivocal, what you can do is you can rescan in a few days, or take another look, because pyloric stenosis can be self-limiting. So it's like more. The risk benefit here, something to consider, is that it's better to kind of get the diagnosis right than risk sending someone who's ultimately normal to surgery. So you want to be, very specific with this sort of exam. And so even though this ultrasound exam is very focused on looking at the pyloric region of the stomach, in rare instances, you may see other pathology that could explain what's going on. I mean, other things that may present like this are like mass lesions, Spiezors, obstructions at other sites, a web, these sorts of things are potential considerations in the setting of, a presentation that gives you a sense of upper abdominal obstruction. So that's something to be looking out for on all the images as a potential alternative explanation if you're not really kind of coming up to a clear clinical, if the clinical picture's not coming together with what you're seeing on the images. And you want to also be correlating with prior imaging and the level of clinical suspicions for various entities in doing that. Okay, so just as a review, big picture, what are we doing when we look, do an ultrasound for pyloric stenosis? You want to understand the patient, understand what is the nature of their vomiting. You're again, like, textbook, do they fit the kind of typical, suspicious demographics of between 3 weeks and 3 months, male patients, et cetera. And then we're going to troubleshoot and try and find that pylorus. Scanning in the epigastrium, looking near the gallbladder, and then doing a little bit of feeding if we need to, reassure the patient. And then once we get the good images of the pylorus, we're going to be looking for single wall thickness. We're going to be looking for channel length. We're going to be looking for any potential movement of things through the the pyloric, the channel in the pylorus. And then we're going to just be making sure that we are looking for alternative explanations, whether it's mucosal thickening, whether it's other obstructive lesions, whether there's anything else that could be a potential explanation for the patient's presentation.